Chapter: Upper Gastrointestinal Bleeding. Introduction. Upper gastrointestinal bleeding, UGIB, refers to any hemorrhage that arises from the gastrointestinal tract proximal to the ligament of Treitz, which includes the esophagus, stomach, and duodenum. UGIB is a medical emergency associated with significant morbidity and mortality, particularly in older individuals and those with comorbid conditions. The clinical presentation can vary from mild, self-limited bleeding to life-threatening hemorrhage. Early recognition, resuscitation, appropriate risk stratification, and targeted management are crucial to improving patient outcomes. Etiology. The causes of UGIB are diverse and can be classified into several major categories. Peptic ulcer disease, PUD, the most common cause. Gastric and duodenal ulcers may erode into arteries, leading to brisk bleeding. Esophageal varices, in patients with portal hypertension, typically due to cirrhosis, dilated submucosal veins in the esophagus can rupture. Mallory-Weiss tears, longitudinal mucosal lacerations at the gastroesophageal junction caused by forceful vomiting or retching. Gastritis and duodenitis, inflammation from alcohol, NSAIDs, stress, or Helicobacter pylori infection can lead to bleeding. Esophagitis, severe inflammation from reflux disease, infections, especially in immunocompromised patients, or pills. Malignancies, cancers of the esophagus, stomach, or duodenum can ulcerate and bleed. Vascular lesions, such as Dieulafoy's lesion, abnormally large submucosal artery, or angiodysplasia. Iatrogenic causes, following endoscopic procedures or surgery. Pathophysiology. The bleeding mechanism varies by the underlying cause. Ulcers erode into blood vessels. Portal hypertension leads to venous rupture. Inflammation or neoplasm weakens mucosal integrity. Mechanical trauma, vomiting, causes tears. Regardless of etiology, massive bleeding may lead to hypovolemic shock, tissue hypoxia, and multi-organ dysfunction if not rapidly addressed. Clinical presentation. Symptoms of UGIB may vary depending on the rate and volume of bleeding. Hematemesis, vomiting of blood fresh, bright red, suggests brisk bleeding, while coffee ground emesis suggests slower bleeding and partial digestion of blood. Melena, passage of black, tarry stools, indicating digestion of blood within the gastrointestinal tract, typically requires at least 50 to 100 milliliters of blood. Hematochezia, passage of fresh blood per rectum, usually a sign of lower GI bleeding but can occur in massive UGIB with rapid transit. Other signs and symptoms include dizziness, syncope, suggesting significant blood loss. Fatigue, pallor, due to anemia. Hypotension and tachycardia, suggesting hypovolemia. Physical examination. Vital signs, tachycardia is often the first sign of volume loss. Hypotension, especially orthostatic hypotension, indicates more severe bleeding. Skin, pallor, diaphoresis, cool extremities. Abdomen may reveal tenderness, guarding if perforation is suspected. Other signs, jaundice in cirrhotic patients, signs of chronic liver disease, spider angiomas, ascites. Diagnostic evaluation. Laboratory studies. Complete blood count, CBC low hemoglobin and hematocrit. Initial levels may be deceptively normal, serial measurements are essential. Blood urea nitrogen, BUN, and creatinine, elevated BUN relative to creatinine, 30:1 ratio, suggests upper GI bleeding due to digestion of blood. Coagulation profile, international normalized ratio, INR, prothrombin time, PT, activated partial thromboplastin time, APTT, especially important in patients with liver disease or anticoagulant use. Liver function tests, to evaluate for cirrhosis and portal hypertension. Type and cross-match, preparation for potential blood transfusion. Imaging and endoscopy. Nasogastric, NG, tube lavage, can help determine if bleeding is ongoing. Esophagogastroduodenoscopy, EGD, the gold standard for both diagnosis and therapeutic intervention, performed urgently after stabilization. CT angiography, useful when bleeding is ongoing but endoscopy is non-diagnostic. Tagged red blood cell scan, highly sensitive but not first-line due to low specificity. Management. Initial stabilization. Resuscitation follows the principles of Advanced Trauma Life Support, ATLS. Airway, protect the airway, especially in those with altered mental status or massive hematemesis. Breathing, ensure adequate oxygenation, administer supplemental oxygen. Circulation, establish 2 large bore 4 lines, initiate crystalloid resuscitation, e.g., normal saline, and prepare for blood transfusion. Target, maintain systolic BP greater than 90 mm of mercury and HR less than 100 bpm. Pharmacologic therapy. Proton pump inhibitors, PPIs, high-dose intravenous PPIs, e.g., pantoprazole 80 mg bolus followed by 8 mg per hour infusion, stabilize clots over bleeding ulcers. Vasopressors, if hypotension persists despite fluids. Octreotide, in suspected variceal bleeding, reduces portal venous pressure. Antibiotics, ceftriaxone is recommended in cirrhotics to prevent spontaneous bacterial peritonitis and sepsis. Endoscopic intervention. Performed once the patient is hemodynamically stabilized. Ulcer bleeding, treated with injection, e.g., epinephrine, thermal therapy, heater probe, bipolar coagulation, or mechanical therapy, hemoclips. Variceal bleeding, endoscopic band ligation is preferred, sclerotherapy is an alternative. Other interventions. Balloon tamponade, temporary measure for variceal bleeding if endoscopy fails. Transjugular intrahepatic portosystemic shunt, tips in refractory variceal hemorrhage. Surgery, last resort for patients who fail endoscopic therapy and cannot be stabilized. Risk stratification. Several scoring systems assist in decision-making. Glasgow-Blatchford Bleeding Score, GBS, determines need for urgent intervention. Rockall score, predicts risk of mortality and rebleeding based on clinical and endoscopic findings. Patients with low scores can be safely managed as outpatients, whereas high-risk patients require intensive care. Complications. Hypovolemic shock. Acute kidney injury. Respiratory failure. Death. Rebleeding, particularly in variceal or large ulcer bleeds. Prognosis. Mortality rates for UGIB range between 2 to 10%, depending largely on the underlying cause and patient comorbidities. Early endoscopic therapy significantly improves outcomes. Patients with variceal bleeding generally have a worse prognosis compared to those with peptic ulcers. Prevention. Eradication of H. pylori in peptic ulcer disease. Use of PPIs for patients on chronic NSAIDs or antiplatelet therapy. Alcohol abstinence and liver disease management to reduce variceal bleeding risk. Beta blockers, e.g., propranolol, in cirrhotic patients for primary and secondary prevention of variceal bleeding. Summary. Upper gastrointestinal bleeding is a potentially life-threatening condition requiring a methodical approach, early recognition, prompt resuscitation, targeted diagnosis, and definitive treatment. Advances in endoscopic therapy, critical care, and pharmacological adjuncts have dramatically improved the survival of patients with UGIB. Mastery of the principles of management, awareness of the high-risk signs, and understanding the nuances of different causes are essential for every clinician. Chapter continued, specific causes of upper GI bleeding. Peptic ulcer bleeding. Pathophysiology. Peptic ulcers form due to an imbalance between mucosal protective factors, mucus, bicarbonate secretion, and damaging factors, gastric acid, pepsin. Helicobacter pylori infection and NSAID use are primary causes. Ulcers that penetrate into blood vessels, especially branches of the gastroduodenal artery, can cause significant hemorrhage. Risk factors. H. pylori infection. Chronic NSAID or aspirin use. Smoking. Corticosteroid use, especially combined with NSAIDs. Severe physiological stress, e.g., burns, head trauma. Clinical features. History of epigastric pain, often relieved by food, duodenal ulcer, or worsened by food, gastric ulcer. Sudden onset of hematemesis or melena. Occult bleeding may present only with iron deficiency anemia. Diagnosis. Endoscopy is diagnostic and therapeutic. Forest classification is used during endoscopy to predict rebleeding risk. OIA, active spurting bleed. OIB, oozing bleed. OIIA, visible vessel. OIIB, adherent clot. OIIC, flat pigmented spot. O3, clean base. Management. For PPI therapy, reduces rebleeding risk. Endoscopic therapy, for ulcers with active bleeding, visible vessels, or adherent clots. H. pylori eradication, with triple therapy, PPI plus amoxicillin plus clarithromycin. Avoidance of NSAIDs, or use with co-prescribed PPI if unavoidable. Secondary prophylaxis, long-term PPI in high-risk patients. Case scenario, peptic ulcer bleeding. Patient, 68-year-old male, history of osteoarthritis on daily ibuprofen. Presentation, several episodes of melena, dizziness. Vitals, BP 88/60ths mmHg, HR 118 BPM, RR 20 per minute, SpO2 95% RA. Examination, pale conjunctiva, dry oral mucosa, mild epigastric tenderness. Labs. OHB, 7.2 g/dl. OBUN, 38 mg per deciliter. O-creatinine, 1.2 mg per deciliter. Endoscopy, duodenal ulcer with visible vessel, Forest IIA. Management, for fluids, packed RBC transfusion, for PPI infusion, endoscopic clipping, and epinephrine injection. Esophageal variceal bleeding. Pathophysiology. Portal hypertension, typically secondary to cirrhosis, causes dilation of venous channels at the gastroesophageal junction. Varices are prone to rupture, particularly under increased intra-abdominal pressure, leading to massive hemorrhage. Risk factors. Alcoholic liver disease. Viral hepatitis, HBV, HCV. Non-alcoholic steatohepatitis, NASH. Portal vein thrombosis. High-risk signs, large varices, red whale markings, seen on endoscopy, advanced liver disease, Child-Pugh class B or C. Clinical features. Sudden onset massive hematemesis. May present with shock. Often accompanied by signs of chronic liver disease, jaundice, ascites, encephalopathy. Diagnosis. Clinical suspicion in cirrhotic patients with UGIB. Urgent endoscopy confirms diagnosis. Management. Airway protection, due to high risk of aspiration. Volume resuscitation, cautious, avoiding overtransfusion, target HB 7 to 8 g/dl. Pharmacotherapy. Octreotide infusion, 50 micrograms bolus, then 50 micrograms per hour. Prophylactic antibiotics, ceftriaxone 1g4 daily. Endoscopic therapy, endoscopic variceal ligation, EVL, is first line. Balloon tamponade, e.g., Sengstaken-Blakemore tube, temporary measure if bleeding is uncontrollable. TIPS procedure, for refractory bleeding or early recurrence. Secondary prevention. Non-selective beta blockers, e.g., propranolol or nadolol, after recovery. Repeated band ligation every 2 to 4 weeks until variceal obliteration. Case scenario, esophageal variceal bleeding. Patient, 52-year-old male with known cirrhosis, Child-Pugh C, secondary to hepatitis C. Presentation, large volume hematemesis, altered sensorium. Vitals, BP 70/50ths mmHg, HR 140 BPM, RR 28 per minute, SpO2 88% RA. Examination, jaundiced, confused, distended abdomen with shifting dullness. Labs. OHB, 6.5 g/dl. O platelets, 50,000. O INR, 2.5. O total bilirubin, 6.0 milligrams per deciliter. Endoscopy, large bleeding esophageal varices with red whale signs. Management, intubation, for octreotide, for ceftriaxone, blood products, urgent EVL, consideration for TIPS. Other important causes of UGIB. Mallory-Weiss tear. Caused by forceful vomiting. Small mucosal lacerations at gastroesophageal junction. Generally self-limited. Gastric cancer. Ulcerated tumors may cause bleeding. Weight loss, early satiety, anemia are warning signs. Biopsy necessary during endoscopy. Doulofoy's lesion. Large caliber artery in submucosa, usually in proximal stomach. Can bleed massively. Requires endoscopic therapy, coagulation, clipping. Special considerations. Bleeding in anticoagulated patients. Reversal of anticoagulation must be prompt. Vitamin K, fresh frozen plasma, FFP, or specific reversal agents, e.g., idarusazumab for dabigatran, depending on the medication. UGIB in pregnancy. Rare, but variceal bleeding risk is increased due to elevated portal pressures. Resuscitation is similar but must ensure fetal monitoring. Clinical algorithms. Approach to suspected UGIB. 1. Initial assessment ABCs, airway, breathing, circulation. 2. Resuscitate fluids, blood products if needed. 3. Risk stratify Glasgow-Blatchford or Rockall score. 4. Urgent EGD within 24 hours, diagnostic and therapeutic. 5. Specific interventions based on etiology, PPI, octreotide, band ligation. 6. Monitor and plan secondary prevention. Summary table. Etiology, presentation, diagnosis, treatment. Peptic ulcer disease, hematemesis, melena, pain, EGD4, PPI, endoscopic therapy. Esophageal varices, massive hematemesis, shock, EGD, octreotide, EVL, tips. Mallory-Weiss tear, small volume hematemesis, EGD supportive, rare clipping. Gastric cancer, occult bleed, weight loss, EGD, biopsy, surgery, oncology referral. Doulofoy's lesion, sudden, massive bleeding, EGD, endoscopic coagulation. Section 1. What is upper gastrointestinal bleeding? So first things first, what exactly do we mean by upper GI bleeding? UGIB refers to any bleeding that comes from the gastrointestinal tract above the ligament of Treitz. That's the esophagus, the stomach, and the first part of the small intestine, the duodenum. This isn't just a little nosebleed inside your gut. UGIB can range from a small trickle to a catastrophic hemorrhage that leads to shock and death if not managed correctly. Underscore. Section 2. Causes of UGIB. Underscore. The most common culprit? Peptic ulcer disease. Ulcers that eat into a blood vessel can bleed profusely. Other important causes? Esophageal varices, those fragile veins that burst in cirrhotics. Mallory-Weiss tears from violent vomiting. Gastric cancers. And sneaky vascular lesions like Doulofoy's. Each cause has its own fingerprint, its own signature story, if you know how to listen to the patient and read the signs. Underscore. Section 3. How does it look in real life? Underscore. Picture this. A 68-year-old man who's been popping ibuprofen for years shows up dizzy and pale, complaining of passing black, tarry stools. Or a 52-year-old cirrhotic patient bursts into the ER vomiting buckets of bright red blood, gasping for air. In both cases, your instincts have to be sharp. Vitals tell you a lot. Tachycardia, first sign of trouble. Hypotension, getting dangerous. Cool, clammy skin, your patient is tanking. And the patient's stool? Melena, that classic black stool, usually means upper GI bleeding. Hematemesis, vomiting blood, is even more direct. Underscore. Section 4. The first moves that save lives. Underscore. Step 1. Stabilize the patient. Think of ABCs. Airway, protected if there's massive vomiting. Breathing, oxygen. Circulation, fluids, blood transfusion if needed. 2 large bore IVs. Send for CBC, coagulation profile, blood typing. Start an 4-proton pump inhibitor right away, a high-dose bolus of pantoprazole, then a drip. If you suspect varices, start 4-octreotide. Cirrhotics? Prophylactic antibiotics like ceftriaxone. You want to get control early, before things spiral out of hand. Underscore. Section 5. Endoscopy, your best friend. Underscore. Endoscopy is the superstar here. Once your patient is reasonably stable, get that scope in within 24 hours. It's diagnostic and often therapeutic, meaning you can see the source of bleeding and fix it in one shot. For ulcers, you might clip it, cauterize it, or inject adrenaline. For varices, you band them. If you can't stop the bleeding, then it's time to call for reinforcements, maybe balloon tamponade or even a TIPS procedure to decompress the portal system. Underscore. Section 6. 2 major causes in detail. Let's break down the 2 big ones. Peptic ulcer bleed. O linked to NSAIDs and H. pylori. O presence with melena or coffee ground emesis. O treated with 4 PPIs and endoscopic therapy. Esophageal variceal bleed. O happens in cirrhotics. O massive hematemesis. O treated with octreotide, antibiotics, and urgent band ligation. Big difference, varices kill fast. Ulcers usually give you a bit more time, but both need urgent attention. Underscore. Section 7, Real-life cases. Quick snapshots. Case 1. 68-year-old man. Black stools. BP 88/60, HR 118. Hemoglobin 7.2. Endoscopy shows a duodenal ulcer with a visible vessel, clipped and injected successfully. Case 2. 52-year-old cirrhotic. Vomiting bright red blood, confused. BP 70/50, HR 140. Hemoglobin 6.5, 2.5 Indian rupees. Found to have bleeding varices banded after octreotide drip and antibiotics. Both survive, but only because the team recognized the signs, moved fast, and treated smart. Underscore. Section 8, Final words. Underscore upper GI bleeding is all about speed, skill, and strategy. Remember. Stabilize first. Diagnose next. Treat decisively. Your patient's life literally depends on it. Thanks for tuning in to MedMaster today. If you like this episode, follow us for more high-yield breakdowns that could one day help you save a life. Stay sharp, stay curious, see you next time. Underscore. Part 1, Setting the Stage, What is UGIB? Underscore. So let's start simple. Upper gastrointestinal bleeding means bleeding that's coming from a source proximal to the ligament of Treitz. That's the mouth, esophagus, stomach, and duodenum. This isn't rare. UGIB accounts for nearly 100 hospital admissions per 100,000 adults annually. And here's the thing. Mortality can range from 2 to 15%, depending on the cause and how fast you act. Early aggressive management saves lives. So you have to know how to recognize, stabilize, investigate, and treat it like second nature. Underscore. Part 2, Causes, the big 5 you need to know. Alright, when you hear UGIB, your mind should immediately pull up 5 major categories. Number 1, peptic ulcer disease, still the leader of the pack. Number 2, esophageal varices, dangerous and fast bleeding. Number 3, Mallory-Weiss tear, mucosal tears after retching. Number 4, gastric cancer, don't miss it in older adults with anemia. Number 5, Dieulafoy's lesion, a rare but devastating arterial source. There are others: erosive gastritis, angiodysplasia, but if you memorize these 5, you'll cover 90% of cases. Underscore. Part 3, The Anatomy of Bleeding. Underscore. Let's nerd out for a second. Bleeding can happen in several ways. Arterial, fast, pulsatile, life-threatening. Think of a bleeding duodenal ulcer. Venous, slower, but can still overwhelm the patient, like esophageal varices. Capillary, minor, but can add up over time. And the appearance of the blood gives you clues. Bright red hematemesis? Active bleeding. Coffee ground vomit? Older blood that's been partially digested. Melena? Black, tarry stool from digested blood. And yes, sometimes a brisk upper GI bleed can even present as bright red blood per rectum. That's called hematochezia from UGIB, and it means very fast bleeding. It's rare but critical to recognize. Underscore. Part 4, Clinical Presentation, Listen to the Body. Underscore your patient walks into the ED, pale, clutching their abdomen. Here are the vital signs you check immediately. Heart rate, tachycardia is the first sign of blood loss. Blood pressure, hypotension, especially orthostatic, is a late and dangerous sign. Respiratory rate may increase to compensate for hypoxia. Mental status, anxiety early on, confusion later suggests shock. Skin, cool, clammy, mottled equals poor perfusion. And don't forget symptoms. Hematemesis, melena, weakness, syncope. The story often tells you the diagnosis if you just listen carefully. Underscore. Part 5, Real Case Scenario, Peptic Ulcer Bleeding. A 70-year-old man comes into the ER. He's been having epigastric pain for a few weeks, thought it was just indigestion. Last night, he had 2 episodes of vomiting, one with fresh blood. Today, he passed black tarry stools. Vitals. BP 90 of 55. HR 120. RR 22. SpO2 95% on room air. He's pale, diaphoretic. Abdominal exam is soft but tender in the epigastrium. Labs show. Hemoglobin 7.8 G/dl. BUN elevated at 38 mg per deciliter, that's from absorption of blood proteins in the gut. Creatinine 1.1 mg per deciliter. You stabilize him, 2 large bore IVs, fluids, cross-match blood, start a high-dose PPI infusion. Endoscopy shows a duodenal ulcer with a visible vessel, a forest IIA lesion, which the endoscopist successfully clips and injects with epinephrine. Outcome? He's discharged 5 days later after H. pylori eradication therapy and PPI maintenance. Underscore. Part 6, Life-Saving First Steps, the Golden Minutes. Now, what's your immediate checklist in UGIB? Think ABC. A. Airway. If they're vomiting large amounts, consider early intubation. Protect that airway. B. Breathing. Give oxygen. Correct hypoxia. C. Circulation. For access. 2 large bore 18G or 16G lines. Bolus crystalloids. Blood if needed. And what about blood transfusion targets? For most patients, target hemoglobin 7 to 8 G/dl. If they have ischemic heart disease, aim slightly higher, 9 to 10 G/dl. Pearl, overtransfusing too quickly can worsen bleeding by raising portal pressures or breaking clots. Be smart. Be strategic. Underscore. Part 7, Special Cases, Esophageal Varices. Tone shifts, serious. Underscore now, if you think your patient has cirrhosis, suspect esophageal varices. These are thin-walled, pressure-loaded veins that can explode under stress. Management pearls. Start octreotide immediately, 50 micrograms bolus, then 50 micrograms per hour. Give prophylactic antibiotics, usually ceftriaxone. Prepare for urgent endoscopy, band ligation is the treatment of choice. If uncontrolled, consider Sengstaken-Blakemore tube or early TIPS procedure. Important. Variceal bleeders need beta blockers, propranolol or nadolol, after stabilization to prevent future bleeds. And mortality in variceal bleeds? Still around 20 to 30%, even in 2025. Part 8, Risk Stratification Tools. Underscore, how do you figure out who needs urgent intervention versus close monitoring? 2 scores you should know. Glasgow-Blatchford score, GBS uses hemoglobin, BUN, blood pressure, pulse, melena, syncope. Rockall score includes age, hemodynamics, endoscopic diagnosis, and stigmata of recent hemorrhage. A GBS of 0? Safe for early discharge without patient follow-up. Otherwise, admit and manage aggressively. Underscore. Part 9, Final Clinical Pearls. Let's summarize the pearls you can't afford to forget. Tachycardia before hypotension, always an early sign of shock. Coffee ground vomit still means active GI bleeding. Always start PPI in suspected non-variceal bleeding. Suspect varices in any patient with cirrhosis. Protect the airway if massive hematemesis is ongoing. Don't overtransfuse, target hemoglobin wisely. Early endoscopy within 24 hours is critical. And remember, even after you control the bleeding, search for and fix the underlying cause. That's what saves lives in the long run. Underscore. Art 1, what if they bleed again? Recognizing rebleeding. Underscore, so you've stabilized your patient. They had a good endoscopy. They're chilling on the floor. Then suddenly, tachycardia. Drop in blood pressure. Fresh hematemesis. Rebleeding happens in up to 20% of patients. And it's deadly if you miss it. Clinical signs of rebleeding. New hematemesis. Fresh melena after it had resolved. Hemodynamic instability. Rising BUN without another cause. If rebleeding happens, resuscitate again. Repeat endoscopy ASAP. Consider angiographic embolization if second endoscopy fails. And remember, after 2 failed endoscopic therapies, it's time to talk about surgery or interventional radiology. Underscore. Part 2, Rare and Dangerous Causes of UGIB. Underscore, let's go beyond ulcers and varices. Here's your rare but high-yield list. Aortoenteric fistula. Especially in patients with prior aortic grafts. Herald bleed, small bleed, followed by catastrophic bleeding. Diagnosed by CT angiography, but high clinical suspicion is critical. Doulofoy's lesion. A large submucosal artery eroding into the stomach or duodenum. Presence with massive bleeding but no visible ulcer. Treated by endoscopic coagulation or clipping. Gastric antrovascular ectasia, GAVE, watermelon stomach. Seen in cirrhosis or scleroderma. Looks like red stripes radiating from the pylorus. Treated with endoscopic ablation. Angiodysplasia. Vascular malformations, more common in older adults. Can be sporadic or linked to chronic kidney disease. Diagnosed on endoscopy or CT enterography. Cameron lesions. Erosions in hiatal hernias. Chronic blood loss leading to iron deficiency anemia. Knowing these rare causes can save your patient when the usual suspects are ruled out. Underscore. Part 3, Imaging in upper GI bleeding, when and how. Underscore, if the source isn't found on endoscopy, or if endoscopy isn't available, imaging steps up. Options. CT angiography. Fast, non-invasive. Can detect active bleeding at rates as low as 0.3 milliliters per minute. Helps locate the bleeding site for embolization. TAG RBC scan. Nuclear medicine. Very sensitive for slow bleeds, but poor localization. Slower to perform. Catheter angiography. Diagnostic and therapeutic. Can embolize actively bleeding arteries. Bottom line. Use CTA if you need a quick localization. Use cath lab intervention if bleeding is brisk and endoscopy fails. Underscore. Part 4, Advanced Endoscopic Therapies. Underscore, let's talk cutting-edge tools. Hemospray, TC325. An inorganic powder sprayed over bleeding sites. Forms a mechanical barrier. Great for diffuse bleeding where clips and cautery won't work. Over-the-scope clips, OTSC. Like a big bear trap for ulcers or fistulas. Provides stronger closure than traditional clips. Endoscopic suturing devices. Used in selected centers to close large defects or bleeding ulcers. These tools are changing the way we manage UGIB and saving patients who once would have needed surgery. Underscore. Part 5, Portal hypertension bleeding, beyond varices. Underscore, we all know about esophageal varices, but portal hypertension can cause bleeding elsewhere too. Gastric varices, tougher to manage than esophageal. Portal hypertensive gastropathy, diffuse oozing. Ectopic varices, bleeding from rectum, duodenum, or surgical stomas. Gastric varices require a different approach. Glue injection, cyanoacrylate. Tips: transjugular intrahepatic portosystemic shunt, if bleeding is uncontrolled. Always remember, octreotide doesn't cure the portal hypertension. Only tips reduces portal pressure dramatically. Underscore. Part 6. What about surgery? When is it needed? Underscore. Surgery is a last resort, but when it's needed, don't hesitate. Indications for surgical intervention. Failure of endoscopic therapy after 2 attempts. Refractory massive bleeding. Suspected malignant cause of bleeding. Surgical options. Oversewing of bleeding ulcers. Partial gastrectomy for malignant bleeding. Portosystemic shunting for variceal hemorrhage. Surgery carries a high mortality rate, 30 to 50% in unstable patients, so it's a decision you make only after all else has failed. Underscore. Part 7, quick review, don't forget these. Let's wrap up with rapid-fire pearls. Always protect the airway in massive hematemesis. Octreotide and antibiotics in suspected varices. Start PPIs early for suspected ulcer bleeds. 2 large bore IVs, no excuses. Don't overtransfuse, aim for hemoglobin 7 to 8G/DL. If bleeding recurs, resuscitate, repeat endoscopy, and consider angiography. Rare causes kill if you miss them, think aortoenteric fistula in graft patients. Stay paranoid. Stay systematic. That's how you win against UGIB. Underscore. Pearl 1. Upper GI bleeding is bleeding proximal to the ligament of Treitz. Pearl 2. Main causes? Peptic ulcer disease. Varices. Mallory-Weiss tear. Gastric cancer. Dieulafoy's lesion. Pearl 3. Hematemesis equals vomiting blood. Coffee ground emesis equals slower or minor bleeding. Pearl 4. Melena equals black, Terry stool equals 50-100 ml of blood in the gut. Pearl 5. Hematochezia can still be upper GI bleeding if it's brisk. Pearl 6. First vital sign abnormal in shock? Tachycardia, not hypotension. Pearl 7. 2 large bore IVs. At least 18G, preferably 16G. Pearl 8. Initial resuscitation equals 4 fluids plus type and crossmatch plus oxygen. Pearl 9. Transfuse if hemoglobin 7G/DL. Target 7 to 8 unless cardiac history, then 9 to 10. Pearl 10. PPIs reduce rebleeding risk in peptic ulcers. Start high-dose esomeprazole or pantoprazole drip. Pearl 11. In suspected variceal bleeding. Start octreotide, 50 micrograms bolus, 50 micrograms per hour infusion. Give ceftriaxone 1G4 daily to prevent infections. Pearl 12. Rebleeding happens in 15 to 20%. Suspect if new hematemesis or hypotension. Pearl 13. Failure after 2 endoscopic treatments? Move to IR embolization or surgery. Pearl 14. Aortoenteric fistula equals massive bleed in patient with a history of AAA repair or grafts. Pearl 15. Dieulafoy's lesion equals massive arterial bleeding without an ulcer. Think endoscopic clipping. Pearl 16. Watermelon stomach equals gastric antral vascular ectasia, GAVE, managed with ablation. Pearl 17. CT angiography detects active bleeding down to 0.3 milliliters per minute. Pearl 18. Hemaspray is great for diffuse oozing when mechanical methods fail. Pearl 19. TIPS procedure dramatically lowers portal hypertension, life-saving for refractory variceal bleeds. Pearl 20. Surgical intervention equals last resort. High mortality 30 to 50% if unstable. Use wisely. Remember. Resuscitate first. Endoscopy early. Think beyond ulcers. Always protect the airway if you're worried. Thank you so much.